Just wanted to welcome you all to this webinar. It's the first one that I've presented, and hopefully it's directed at a broad range of my colleagues, and hopefully you'll find this useful. The title is Enhancing Ocular Surgery Outcomes with Surgical Technologies and Techniques, and specifically relates to 3D microscopy, which I've now been using for almost 18 months to 2 years here in Brisbane, Australia. So for those of you who aren't familiar, Australia is somewhere down the bottom of the world, and I am located in Brisbane, which is on the east coast and the capital of the state of Queensland. We're a growing city of about 2.5 million, and I guess our claim to fame in the next 7 years or so will be hosting the Olympic Games. I think by that stage we should probably have over 3 million people. So we're not a huge city, but we're not a small one either. In terms of myself, I'm a general or anterior segment ophthalmologist. Do lots of cataract surgery and lots of glaucoma surgery, and work in a private practice in an area called Redlands, which is just outside of Brisbane. Public hospital that I work at is called the Mater Hospital in Brisbane itself, and that's where I do most of my teaching. Our practice has 5 ophthalmologists and 3 full-time, and we now offer full scope service, including a vitreoretinal service. So just wanted to show you this little video, which is, I guess, a promotional video of our theatre in the hospital across the road from us where we operate. And the C-Luma is a fully digital microscope. It does have binoculars, but we don't actually use these, but use these 3D glasses. Its unique feature is it has a C-shaped arm, which means you don't have to bend your neck and look past the binocular apparatus, but can look straight ahead. It has 2 beautiful high-definition screens, a 30-inch one attached to the scope itself, and then a freestanding 50-inch screen as well. So why did we look to digital microscopy, and what were we hoping for? Well, we were looking for better visualization, which, as you all know, makes surgery that much easier. We were looking for an improvement in ergonomics, and I guess this is something that has become more relevant to me as I have grown a bit older and been working for longer. It has improved our workflow, and this, I think, is relevant to, shall I say, developed countries and under-resourced areas where you are struggling to meet demand, and anything that makes you more efficient is helpful. And then obviously from a teaching and education viewpoint, we were looking for something that would help with that. And that was looking for something that was more than just a recording platform. So in terms of visualization, the scope itself has been extraordinary. And until you actually try one of these things, it's just words, but the depth of focus, it's truly amazing. So what I found is that I hardly ever to focus during a standard case. Once I set the scope up with my glasses on, the cornea, the scleroconjunctiva, the anterior chamber, even as far down as the posterior capsule is pretty much in focus. You can obviously tweak this with your foot pedal, but more often than not, it's not really necessary. And the second thing is the field of view is also extraordinary. And I found this probably most relevant during the IA stage of surgery. Initially, I thought I was imagining it, but after discussing this with other colleagues who have trialed the scope, my commentary that I felt that I was looking around the corner uh, was not just in my head. So in terms of ergonomics, the ability to sit straight and to look straight ahead without having to tilt the neck, without having your neck extended or flexed, and also the relaxation in the shoulders is significant. More so when you're doing a full day operating, especially so if you're doing more than uh, one day in a row of surgery. And for the youngsters out there, you probably don't understand what this means, but you will in time. And I guess the old adage, physician, heal thyself, comes into play where you are, well, it's necessary for you to look after your own health in order to provide uh, excellent care for your patients. So this is a little video highlighting my position during surgery. You'll note that the chair here supports most of the way up my back, and I'm really sitting back in a very relaxed position, not hunched over the patient and looking straight ahead whilst operating at a comfortable distance away from me. And I'll just play the video, which is really just shot live whilst we're performing a case. The lighting is not super dark in the room, but you can see that I am resting back comfortably with my arms a little bit away from me. And this is a change from standard analog microscopes where you are often right up at the eyepiece and your hands a little bit further down. So this sort of relaxed position is found to be extremely beneficial to my comfort whilst operating and hopefully the accuracy of what I do, especially towards the end of the day. Just struggling to go to the next slide. There we go. So you may ask why ergonomics, and it wasn't until I did a little bit of research into this that I was able to discover that there is a lot of literature out there about the issues faced by ophthalmologists. And most of this is related to back and neck pain. As you can see from these quoted studies, and there are many more, most of the respondents report either back or neck pain or both. And moving forward, we see that at least a third of us have reported some pain whilst operating, and 3/4 of these people have found that operating, especially towards the end of the day, makes this worse. So again, in a young person's agile body, it's probably not such a big deal, but after 15, 20 years of high volume work, I think you'll find that your not life expectancy, but shall we say work expectancy is reduced significantly. And that's certainly been the case in our group, amongst our cohort of surgeons utilising this, insofar as one of my colleagues feels that she's probably added 5 to 10 years in terms of her operating working life, certainly has a much more comfortable existence since switching to this technology. The workflow, really it's the consistency from image to image and from case to case. It's really easy to set up. The 55-inch monitor, it's incredible. And The other thing that it allows is everybody in the room, with the addition of glasses, they don't have to wear it, but the image is obviously doubled given it's a 3D scope. But with the glasses on, everybody's seeing what you're seeing, which is spectacular, but also allows your assistant staff or nursing staff to predict what's going on, what you're up to, and allows truly the ability for you to focus on what you're doing and simply place your hand out, hopefully receiving the instrument that you're awaiting. From a teaching and education perspective, the ability to teach without being right next to somebody, which often adds stress to the student or resident or registrar, is fantastic. So you can be a little bit away explaining what you'd like to impart without crowding the operating surgeon. You also have the ability to draw on the screen, pointing out where you'd like them to attempt maneuvers or things to touch, not touch, avoid, etc., which is really the way of the future. The recording is of extremely high quality, and I will show you some cases shortly. And the next part of this is the ability to record in 3D, which I'm currently working through with the company as we speak. There aren't many of these units currently in use worldwide, and we're very fortunate to have one. But it has been life-changing for us and allowed us to hopefully offer fantastic surgery to our patients. So I just want, excuse me, just wanted to show you some examples of the surgery that we can perform using this scope. And then I'm going to go through several cases with some tips about cataract surgery, from routine cases to some more complex cases. I have based these videos on some of the questions that were sent in by some prospective attendees, and hopefully they are aimed at the right level. So the red-free surgery I find is really useful as my go-to when there is sort of a dodgy red reflex. With my surgery, I try to minimize how many steps I take and how many instruments I use. So you can see that, this black and white case, the contrast is still spectacular, and you're able to easily perform this without the image being in color. And I use this when the red reflex isn't great, and will often try this view first before resorting to something such as trypan blue or vision blue, as we call it here. So you can see it's easy to distinguish cortex from the capsule. You can easily pick up the wisps. This is the single piece IOL in the bag. Hydration of the wound, some intracameral antibiotic, and a beautiful black and white case. So this is what's known as MIGS, which is minimally invasive glaucoma surgery. Many devices available now. My device of choice is the iStent, and I thought I'd show you the view that you get with a single-use prism showing us the angle, and you can see blood in Schlemm's canal quite clearly here. And I'll play this video. It shows us the eye stent infinite. There you can see the trocar and delivery of the stent. And what's very nice once we come back is to see a little puff of blood indicating we're in the right spot. This is flow glaucoma micro shunt, which is now my go-to procedure and has replaced, in my hands certainly, trabeculectomy. It's a far smaller peritomy. We still use antimetabolites such as mitomycin, but it has helped me provide a much more consistent result in terms of IOP lowering, with a very, very high success rate at the moment. And I can't see myself going back to standard trabeculectomy anytime soon. The next step up from this obviously would be a glaucoma tube device, but it's rare to have to progress to that in standard cases after using this device. And you can see how clear the image is using the digital microscopy. So let's play this video. And you can see as we extend this blade through the sclera partial thickness and then stepped entry into the anterior chamber, all beautifully visible. And insertion of the micro shunt, which has a little winged flange to prevent it going too far into the anterior chamber. And here we can see aqueous beautifully flowing through the tube. This is a 10-0 nylon, which I thread and stent the tube. And this is the finished product. So it's wonderful for sort of these extraocular / glaucoma procedures. Many of you would be experts at small incision cataract surgery. It's something that we do quite infrequently, but it is a lovely skill to have. And again, this microscope allows you to perform this quite comfortably as well. So we can see that wound construction, which is really a challenge in this case. I always use an anterior chamber maintainer, especially when teaching this technique to our residents and registrars who are relatively unfamiliar with this, given that we use phaco 99% of the time, and the maintainer just keeps everything under control, allows very safe delivery of the nucleus without applying pressure, and all in all just adds a level of safety to something which is not performed frequently here quite well. And this is a more complex sort of case here. Just wanted to point out this was a patient that had suffered trauma, and we knew beforehand that there was nodular weakness. We're still planning to place a toric IOL in the bag down the track. And what you can see here is that I have fixed the capsule using Chang capsule hooks, which have a rounded tip to them and are longer than your standard iris hooks. The beauty of these hooks is that they can help you fixate the bag with a far less likelihood of tearing it, but also because of the extra length of the tip, once you insert them, they tend to extend to the equator of the bag. And you can see here where my cursor or pointer is that there's at least sort of 3 to 4 clock hours of zonular dehiscence and the bag sort of flopping over here. just play this video to highlight how you can still safely finish this case. And we just expand the bag, it pushes it back. But you can see it still wants to come over towards the center of the pupil. And I have added an extra chain hook to fixate in the area where there was weakness. We inflate the bag, the hook's in place before taking the rest of the cortex out, and I'm just highlighting where I think the weakness is. So before attempting to remove the cortex, I place a capsular tension ring all the way around inside the bag, which just places it on tension. It's nice to do this relatively slowly so that you don't tear the bag. Once the cortex is out, this is an RNED segment with an 8O Gore-Tex suture, which we then pull out through the sclera, and you can see that it was fixated here and the toric lens in the bag, still aiming to give this patient excellent vision as well as bag stability. So that was just a series of examples of the case types that can be done with very safely with the digital microscopy. We also have many vitreoretinal cases, and our VR colleague uses this with a heads-up display and performs all the whole range of VR surgery with vitrectomies and detachments and buckles, etc., on a regular basis, and really enjoys the scopes. So these are just some cataract surgery cases. Now, these are actually a little bit older, not recorded on the digital scope. And from my point of view, I certainly noticed a decrease in the quality of the recording, but that could be my bias. This is just a standard analog scope, but I'll go through the cases and just highlight my techniques and what I think are important. I do use these videos to teach our trainees, registrars, as we call them in Australia, residents, I think, as they are known in many parts of the world. And I'll just highlight what I think is important to safe and successful surgery. So I don't use pre-op dilation, but I use an intracameral mix of phenylephrine and some lignocaine or lidocaine, which gives you fairly adequate and instantaneous pupil dilation. This is just a heavy viscoelastic and a Zamvisc. I keep my cannula in there and make a stepped wound. One of the questions, I'll just pause that there, was how do you create a wound and avoid damaging decimes? Well, in my case, it's a 3-step wound, and I find that I never, and I probably should never say never, but find that I don't really have any wound leaks with a step wound of reasonable length made at the limbus. In terms of capsular access, yes, you can use assisted time, but I tend to use forceps because of the speed and the accuracy. Just continue the video. And as you can see here, oh, started at the beginning, I apologize. Capsular rexus here. And this technique is leading where I'm trying not to tear, but my forceps tips are way in front of the flap. Release some of the visco. Hydrodissection is simply done one side, decompression on the other, and this is a primary chop technique where you aim for the middle of the nucleus and bring the chopper towards the phaco tip. This is a nice way of separating it with very little ultrasound power. And divide the half into quarters. And what I was attempting to do here is to move it so that you can grab the edge of the piece, which then brings it up, still in the iris plane, but in the center, which is what I call the safe zone of cataract surgery. So this is the capsule guard IA handpiece, which is a silicon tip, and you don't need a split system at all, really, and can safely remove all the cortex through your main incision. So it's just one less wound that you need to make. And given that the tip is silicon, very safe to do a capsule polish at the same time. It's great for your trainees. I guess from a resource point of view, they are single use, so it's probably not the most environmentally friendly way of operating. And again, just trying to highlight capsular rhexis by leading it around and not tearing it, grabbing near the edge and using the iris as my guide. Again, a chop technique from the edge, foot down. You'll notice that my phaco tip, well, I'm attempting to keep it towards the center, not chasing the piece. I'm letting the piece come towards the phaco. And this is single piece IOL, which unfolds very neatly in the bag. Again, small pupil, a little bit of intracameral phenylephrine and lignocaine, and you get adequate pupil dilation. Many people would try and dilate this pupil bigger, but that's plenty big enough to safely take out a cataract. Again, stepped wound and a nick in the capsule. Capsular rhexis. When the pupil's a bit smaller, you simply follow the edge of the pupil. Kind of provides you with a lovely buffer. Hydrodissection one side, decompression on the other, and ensuring that it spins before you attempt phaco. Again, aiming for the center, chopper in, split in half. Split in quarters now, and teasing that piece up, trying to just keep your phaco around the center. The one thing with a small pupil is the iris can very easily get caught in your phaco tip, and so you just have to be a little bit careful where your tip is before putting your foot down and engaging vacuum. And again, capsule guard, always start with your sub-incisional cortex first, do the hard bits first, the rest of it is fairly easy, and then a polish to try and clean the bag prior to IOL insertion. Fill the bag with your viscoelastic. And again, an IOL. And I like these preloaded IOLs because you can simply place them and nearly 90% of the time it will be in the bag without having to manipulate that again. Again, this is a much larger pupil, and I wanted to show you sort of a grooving technique. It's not really divide and conquer, but it's a way of safely disassembling the nucleus by grooving down. So the important thing to think about when doing phaco is, what do I need to do, or how deep do I need to go with the phaco before I can safely crack? And this is probably the thing that most people struggle with as we're learning cataract surgery. And there are some metrics around this, which I think it's important to get your head around. So if we assume that most cataracts in terms of lens thickness are somewhere between 4.5 to 5 millimeters, you want to be at least 3/5 of the way down. So you want to be realistically 3 millimeters down minimum before attempting to crack. Obviously, density does matter. But what really matters is width of your groove and depth of your groove. So many people don't actually think of this from a mathematical viewpoint and just assume that you can judge depth. I think it's important when you are learning this to actually have a measurement. And one way of working this out is to measure your phaco tip, so the amount of tip that is shown. You may notice that I show a fair bit of my phaco tip. We'll just go back to that. And you're looking here, I often leave at least 1.5 millimeters of tip out. And what it then means is if I groove down 2 to 3 times my tip length, I know that I'm past the 3 millimeters. The other thing that's really important here is to look at the width of the groove. It has to be wider than this because of the sleeve. The sleeve, yes, it compresses, but with a dense nucleus, when you place your phaco tip down there and the groove is too narrow, you're effectively putting posterior pressure on the lens. And what you want to be putting is sideways pressure at the bottom of your groove. That's how you divide the lens. So when doing this, if I can just play this from here, you can see I'm making it wide enough that I can place both instruments at the base and just push sideways. It's a very gentle procedure. And then what I've used is the Drysdale or the paddle and chopped that using the neck of that instrument. So it's effectively a blunt instrument, a very safe and a great way to start your cataract journey. The other instruments I was using earlier are various types of choppers, which have a pointy tip and are good for getting into dense nuclei. And here we have another polish. What I wanted to highlight here is the Malyugin ring. So in terms of pupil expanders, the iris hook is probably less and less used nowadays. They are fiddly, they're fantastic, but certainly in my hands and from a teaching viewpoint nowadays here in Brisbane, we would use the Malyugin ring far more often. I know there are various iterations invented by many of our brilliant colleagues, but I use this, and this technique is a way of guaranteeing engagement every time. So I do my distal first. When the rest of the Malyugin comes out, there will be one on this side and one on that side, and I just engage one side. You can attempt to engage both, but what that involves is pressing down with the steel introducer, which can damage the capsule. So I find in order to avoid touching the capsule there, what I aim to do is engage one side, and I'll let this play again. So you'll see off to the left. And then I have my second instrument coming out, ensuring that my subincisional one is engaged, and then come back through the main wound and engage the other side. So that you will get it in every time. And now we come to removal. And again, this is a technique that if you utilize, you will be able to remove the Malyugin every time without causing damage. And there have been cases where the ring has caught the capsule, caught the iris, scraped the cornea, and you can avoid all of these by this simple technique. So I place the lens in the bag prior to iron, just fill it up with a bit of visco, protect the endothelium, disengage my subincisional one, The introducer is to the left. Extend the arm. So what was really important was that, and I'll just go back to this, the introducer goes to the left and goes under this. You then extend the hook, and once it's fully extended, you come over to the side, and then when the hook's over the top of this circle, you retract the hook. Play it again, and you'll see it then brings the ring back into a linear formation, which you can then safely remove through the wound without engaging any other structures. Straight, and then out she goes. We see here a lovely white cataract. And one thing I would ask you all to consider is, obviously in your pre-op assessment, working out whether this is a cataract or lens that is under tension. And obviously, prior to piercing the capsule, what I've done here is use a 27 gauge needle on a syringe and pierced and aspirated to try and relieve the tension to avoid what's known as the Argentinian flag sign. Obviously, there are many ways of avoiding this. Some people advocate a preoperative YAG of the anterior capsule. Many other people simply pierce the capsule with the phaco tip itself, which obviously creates a much larger wound with aspiration to try and decompress this. I've just used a needle here. Keep playing this. So again, capsular rhexis, trying to lead this around, which reduces your risk of losing the capsule. Obviously, if you're concerned at all, stop and refill with viscoelastic just to flatten it out. And we get a nice circular rhexis. And what I wanted to highlight here is what I call teasing the lens apart. Often you're required to do this in leathery cases, post-vitrectomy cataracts, for example. And what happens here is my right hand here with the phaco tip has engaged a piece, and this is effectively still. It is the left hand that teases this piece apart. So one hand is still, and the second hand teases the piece apart. You've just got to be patient and gentle and operate at the base of the pieces. And again, on the last piece here, I place a blunt instrument underneath the phaco tip so that there isn't sudden surge. Capsular tension ring, which I often use. In many cases, it keeps the capsule under tension, and I find my effective lens position is really predictable. It also allows me the options of lens exchanges down the track should I wish to change people's refractive outcomes. I don't chase all of the wispy cortex pieces in these dense traumatic cases. Last thing I want to do is puncture the bag. And if there is some PCO down the track, it is simple enough to perform a YAG capsulotomy, which is far better for the patient than busting the bag and having to do a vitrectomy and placing a lens in the sulcus. Just move on now to the last few tips. So again, stabilize with the visco, stepped wound, pierce the capsule. Capsular rhexis. I guess the key to good surgery is not to rush, but to be smooth. And if you're smooth, you'll be efficient. So I really wanted to show this grooving technique. What I'm trying to show is if it's too narrow, you cannot get both instruments down there. So this is a dense nucleus. So I'm not making it very long. What's really important is I am aiming for depth. Okay, so I can place both instruments at the base and tease the lens apart. This is a really gentle maneuver, but you can see how wide that groove is. Again, we engage and use the neck to separate the piece and engage the edge, which brings it up into the center. Spin this around, engage, stop, very gentle. And before you know it, piece is gone. Stepped wound, piercing the capsule. And again, just taking my time to finish my capsular excis, the hydrodissection to one side, decompress the other, spin the lens. Again, a nice wide groove and concentrating on depth. I'm at the base, split. It is really a very gentle process. This is a chop. Again, you can see it's very, very simple to disassemble a nucleus if you use the right techniques. And the key to all of this is depth, whether with the chopper or with a nice, deep and wide groove. Doesn't need to be long. The length is really not important. But you can see how efficiently we can disassemble and remove a nucleus with either a stop and chop or a straight chop technique. So these were just some basic principles, I guess, of phacoemulsification surgery. What I really wanted to highlight to you in the talk was the advent of digital microscopy and how it has certainly changed my life, has improved my efficiency. I use it across a broad variety of cases, and I feel certainly that my visualization has improved, my ergonomics have improved, and my efficiency and, I guess, technical outcomes have improved as a surgeon. Obviously, the margins are very small. We're already operating, across the world. Surgery from an ocular viewpoint is at a very, very high standard. So all these minute improvements certainly, I feel, make our lives better and certainly our patients' lives better. And I hope that some of these simple techniques have been of use to you. In terms of Queensland, we're known as the most relaxed place in Australia, and I just wanted to show you this little photo. It's in jest. I don't usually have beer in the operating theatre, but I certainly feel very comfortable operating with one hand, with the other one resting on my armrest whilst doing IA and capsular excis, and hope you've enjoyed the talk. I think what we'll do now is go to some Q&A. I have a question here about the video delay relative to real surgery. So both of the screens are wired to the scope, so there's absolutely no delay whatsoever. It's not a wireless connection. The large screen and the screen that's attached to the microscope are wired, so there's absolutely zero delay. Another question here, is fogging a problem in terms of the eyeglasses due to the surgical mask? And it's an excellent question. So the mask I use, certainly to avoid this, has sticky tape across the top. So it's actually a mask that has adhesive on the inside, but I know many of my colleagues just place an adhesive tape over the top of the mask to prevent fogging, very similar to what you would do if you were looking down binoculars. But certainly, no, I've had no problems. So another question here that we have is what type of anesthesia is used for cataract surgery? Certainly, in my practice, it is some IV sedation with an anaesthetist and either a peribulbar or a subtenons or a topical solution, so a topical case. I don't love using topical cataract surgery, mainly because of the amount of patient cooperation that's required. And so I tend to have my patients, relatively sedated, and certainly they appreciate not knowing anything about the surgery and a block. But I do have some very, very experienced anaesthetists who, have been with me for the last sort of almost 12 to 13 years. And so, over 20,000 cases, and they are very experienced. So have no problem using blocks. How much time do we need to wait to prescribe prescription glasses after a cataract operation? So, routinely we like to wait until the eye has healed and the surface has returned to normal. So everything that we use in terms of pre-op sterilizations, either betadine or hexadine solutions, dry the eye out, and then the post-operative care regime with drops, even though we're using preservative-free drops, certainly causes ocular surface issues. And I think it's best to wait until all of that's settled, so 4 to 6 weeks before considering any glasses prescriptions. There's a question here about some pearls about phaco chop and getting a firm grip. So again, this is the whole concept of depth. And, if you are putting that probe into the nucleus, you want to have the tip buried. And so again, if you've got at least 1.5 mils of tip showing, that's a fairly reasonable, I guess, spear tip that you can think of, which impales the nucleus. And then you've got to have your vacuum high enough to hold that piece before attempting the chop. Most chopping fails because the tip is not deep enough. So depth as in, depth of the lens, but also hasn't been speared enough into the phaco piece. Pearls for dealing with small pupils. So, yes, if you have intracameral phenylephrine, that's step one. You can use pupil stretching techniques using 2 second instruments, but I find that's quite traumatic. You will get some bleeding, etc. Iris expanders such as the Malyugin or iris hooks are very useful. They're just time consuming, and I find that if you have at least a 3 to 3.5 millimeter pupil, you can safely take out a cataract without doing anything to the iris using the techniques that I've just shown you. So if you straight chop in the middle of that safe zone and use the chopper, you can easily separate the nucleus into 4 pieces and deliver those through the small pupil. And then the most difficult part of the operation is actually your irrigation aspiration at that point. And that just takes a little bit of practice. I've got a question here about sharing some pearls and how to do a capsulorhexis. So obviously when you first start with a cystotome, that is the safest way to perform capsulorhexis. So you pierce in the center, and if the cystotome is hooked, I would suggest that you move it to the left and pull the capsule towards you. So the hook is designed to pull. Now, what that does is create a flap, which is then in a configuration for you to keep leading that around with your tip anti-clockwise. So if you're sort of looking at the patient and you've pulled that flap towards you, you then lead it anti-clockwise. Now, if you wish to go in the other direction, I suggest that you use a straight needle. So you pierce the lens and move it to the right and then push. So a straight needle is very useful for pushing the capsule. You can then, bend the tip, and again, the flap can then be moved anti-clockwise. If you wish to go clockwise, it's the other way. You'd move to the left and push, or um, move to the right and pull, and then you can go in a clockwise fashion. So start with the capsulorhexis forceps, and effectively what you're doing is you're laying that flat onto the surface of the lens and leading it around. Once you're comfortable doing this, I think the next step is to move to forceps. And again, as I showed you in the videos, the forceps should be in the same plane as the lens, and that way you're leading, you're not pulling or tearing. You can tear, it's far higher risk of losing the rhexis that way. How do you manage the nucleus when one has a bowl during the phaco? Well, you've gotten rid of most of the nucleus if you've created a bowl. And so one technique then is to use some viscoelastic just around the back of the bowl, which then separates that bowl of nucleus from the capsule. You can then place a second instrument and flip that bowl up and eat that remaining bowl, that you've got behind. And all you need to do really is get one edge and it'll come up. It's almost like um, it's a flipping maneuver, but you will need viscoelastic and a blunt second instrument to lift that up. And I find that's the easiest way. Rather than trying to separate the bowl itself, using something sharp whereby you can catch the capsule very easily. In terms of the pressure flows, so we've got an audit now of my last 60 cases, and on average, my IOP is between 8 and 12 post-operatively. So they are really very low, far lower than I've seen many published results. And I do have many videos, so feel free to email me, happy to share those. I do have a couple of videos on YouTube, I think. I need to update that. I've got a question here from South Africa. Yeah, so the use and appropriateness of different chopping techniques, you really just need to find one that you're comfortable with. I don't really vary too much from dividing with a Drysdale, which was that paddle or that non-sharp instrument, and then chopping using the neck of that, or a sharp chopper and straight chopping. And you need to just modify between a vertical and a horizontal chop depending on the density. Some cataracts are really dense, and if you try and vertical chop, in other words, place the chopper straight into the nucleus, it's too dense, and all you end up doing is pushing the piece off your phaco tip. So in those, you need to actually go past the dense nucleus and get into the epinucleus, and it's almost a combination of a horizontal and vertical. So you're going around into the softer part of the nucleus and then bringing that tip towards your phaco tip. So those are probably the three that I would find I can get nearly every cataract out. And if it's too dense, then I sort of revert to small incision cataract surgery to protect the endothelium. So what anesthesia do you prefer on extreme axial length? So, my anesthetist would use subtenons, or we could do topical with a bit of sedation. So what would be the tip for a soft cataract that cannot be fragmented? Look, there's a couple of tips, and these are probably more in the realm of the private cataract surgery that we do for refractive reasons. And so, again, a couple of techniques. One is the onion technique. Basically, this is a hydrodelineation where you delineate into multiple layers and take out each piece like you would an onion. And that works quite well. What I simply like to do, given they're so soft, is simply hydrodissect and cleave as much of the cortex as I can and try to just lift up one edge. Once I've got one edge up, I place my phaco tip inside and move straight to my segment, which is the high vacuum setting, and with a blunt second instrument, flip the whole thing up out of the bag, and it comes out very easily. This is a procedure that will take seconds. Yes, so there's a question about the digital microscope and using corrective glasses. Yeah, you simply place the 3D scope over the top of your prescription and away you go. Yeah, I've certainly. So the question is, have you noticed a reduction in the frequency of intraoperative focus adjustments while wearing the 3D glasses? And the answer is absolutely yes. The depth of field and the field of view have both meant that it is, I hardly use my foot pedal at all. I just set it up from the get-go and can finish most cases. Do I routinely use intracameral antibiotics? I use it 100% of the time, and our endophthalmitis rates are probably less than 1 in 4,000. So practical tips for a novice surgeon starting phaco. We've all been there. Take your time and think, the biggest things that I've highlighted in terms of phaco is making sure you've got a good view, obviously with whatever technology you have available. The second thing is understanding depth. Once you understand depth, and that can be, as I said, using metrics and measurements, or, with time that will become experience, then phaco becomes easy. But a question here, in zonular weakness, how do you decide perioperatively between using a standard CTR or a modified Ciani ring? I think that decision is based on how much zonular weakness you have. And also, a lot of that you'll also decide intraoperatively. So the case that I showed you today, I put the standard CTR in to provide tension before attempting IA. And obviously, with the irrigation aspiration, you don't, pull towards the center as you would normally, but you pull sort of in a modified fashion off to the sides to try and minimize further tension on the zonules. And then once that CTR is in, I sort of see how the bag is sitting. And if I feel like there's still some drift away from the weak area, then I will top that up with the modified Ciani ring or the RMED segment. And it's one of those things I think, look, if I'm there and I'm operating and I don't want to come back, then I will just suture the segment to the sclera, because the worst thing you can do is be in the eye operating and say, look, I'll just leave the CTR in, and then post-operatively you find that the lens has drifted off and you've got to go back again. Another question that we have is, what is your recommendation for a novice surgeon to start heads-up 3D? Really, I think the answer is just dive into it. The learning curve is very quick. I wouldn't even bother with the binocular attachments. I would just put on the 3D glasses and have a go, and you'll find that before you know it, you're very comfortable. I think you'll find that children nowadays who are all playing video games, certainly here in Australia, will pick this up quicker than us. I have another question here. Can I postpone nuclear rotation until performing the first groove so as to avoid any pressure on the zonules caused by one instrument rotation? Look, yes, I think the answer to that is I like to rotate the lens after I have hydrodissected, just to prove that it is mobile, because the last thing you want to do is to have to go back and repeat hydrodissection. So I think what you can do is do a nice groove, split that into two, and then rotate. And you can rotate with one instrument if you feel that the lens is mobile, but two instruments always produces less downward pressure and more rotation whilst operating. So there's a question here, is there any limit in nuclear density to do phaco? And I think the answer is yes. There's nothing that a phaco cannot get through. The question is, how much ultrasound do you think that cornea can take? So really we're talking about endothelial dysfunction. So I decide on this based on their preoperative corneal assessment. Do they have Fuchs dystrophy? How old is the patient? And how much ultrasound do I think I'm going to use? And I guess that's a question for experience, but not all white cataracts are dense, but certainly the brown ones moving to the black ones are very dense. And so I then decide between an extracapsular extraction, such as a small incision, or phaco. We've got a question here about how do I control the flow in PreserFlow microshunt to avoid hypotony, and how often do they clog? So I stent all of my PreserFlows with a 10-0 nylon, which gives you approximately an 18 to 20% reduction in the flow, and certainly that will avoid hypotony. And that suture is then not tied, but buried in the cornea, and I can remove this at a later date at the slit lamp. I also use a mattress suture at the back to ensure that the PreserFlow follows the contour of the globe, and this also helps me to avoid having Tenon's capsule block it up. And the third thing that's really important with the PreserFlow is we use 0.04% mitomycin for a minimum of 3 minutes to try and avoid adhesion around that area. But I have to say it is a far more titratable surgery than standard trabeculectomy in my hands. Got a question here about posterior pole cataracts and how I would approach or the technique be modified. I'm thinking that you're talking about posterior polar cataracts, where there could be an associated capsular weakness. Certainly, the most common technique is to be prepared for vitrectomy in these cases and warning the patients preoperatively. The second thing is to not perform full hydrodissection until the very, very end. So the key is to advance the fluid up until that polar section, but not all the way around. And again, the onion technique or hydrodelineation is what I would use to separate those inner layers of the lens, leaving the epinucleus and cortex, and then slowly peeling all of that away until you're left with only the polar segment, and then taking that out at the end. If you're lucky, it may leave a small circular hole, and if there is, you just need to put some viscoelastic to push any vitreous away, and you can often implant a lens in the bag quite safely. Sometimes, though, the bag will break, and you just have to be prepared for that. I am going to possibly sign out now, ladies and gentlemen, because it's now well past midnight here in Australia. But I certainly hope that it was useful for you, and thank you all very much for signing in from around the world. It's wonderful to have such a fantastic technology where we can share knowledge with each other, and I wish you all the very best. Thank you once again.